Hello, I'm Dr. Natesh, Senior Consultant Orthopedic Surgeon and Professor of Orthopedics. So, I'm going to speak about knee pains. So, first question is, how many types of knee pains are there? There are various types of knee pains. It may be because of autoimmune diseases like psoriatic arthritis or rheumatoid arthritis, because of gout, that is a metabolic disease, or just because of hereditary conditions and because of degenerative process. Out of all these conditions, the main reason for knee pains could be degenerative and age related. The reason for knee pains, especially in young individuals, is most likely because of rheumatoid arthritis or other metabolic disease like gout and psoriatic arthritis. And degenerative arthritis is very rare in young individuals. And for these knee pains, to avoid these knee pains, one should have a healthy body mass index, that is maintaining your body weight to your respective height, and that is body mass index. Second question is, what are the preventive aspects that we can do to prevent knee pains? Yes, knee pains can be prevented by definitely maintaining a very good body mass index, like in many other diseases. Body mass index is maintaining a proper weight, because height is not under our control. We have to maintain proper weight of our body so that it is suitable to our height. And for Asians, the ideal body mass index should be around 22 to 25. If we maintain our BMI in this range, we will definitely reduce our risk. And once the pains have started, once the degeneration or pains have started in the knee joint, it is better to avoid stairs as well as walking for long distances or other things, and to shift our routine exercise activity to swimming or walking in water or cycling or cross trainer or something like that, just to avoid further degeneration of the knee joints. Yeah, there is one more issue, that is surgery, the only knee replacement surgery is the only solution for arthritis of the knee joint. It is not like that. There are many other ways. When we suggest, once the patient comes for the first time, when grade 1, grade 2 osteoarthritis, we suggest him to reduce the body weight, we suggest them to reduce their activity levels, modify their activity levels, we suggest them some few exercises, we give them nutraceuticals that includes some collagen supplements and all. We may even give them PRP injections into the knee joint by taking their blood and centrifuging it, and we give them hyaluronic acid injections into their knee joint, which are FDA approved. And once all these things fail, when the patient mobility is important, because once the patient doesn't move, his maintenance of other conditions, like he will not be able to maintain his body weight, he will not be able to maintain his diabetes, sugar levels, or his blood pressures. For all these things, mobility, walking is very important. So if he is not in a condition to move and maintain all these things, in those situations what we do is we suggest them to go for knee replacement. And in only those conditions we do knee replacement. Select set of patient, we do knee replacement, and usually after knee replacement the success rate will be around 99%. It is a standardized surgery everywhere. And once patient has knee replacement, there will be a phase of physiotherapy, and once physiotherapy phase is over, the patient muscles and all, he regains his strength, he will be able to walk, and he will be in a better position to handle his body weight, he will be in a better position to handle his blood sugars and hypertension. Regarding knee replacement is a surgery where the pain of the patient from the knee joint because of arthritis is not amenable and is not treatable by all other modalities. We go for knee replacement, and once we go for knee replacement, replace the articulating surfaces of the joint. And once the articulating surfaces are replaced, the patient will be walking on those joints. There will be some angles and few positions where we have to place those place those components inside the knee joint, so that the knee will function normally. And once these components are placed inside, the patient will be able to walk on them. The other thing is, so this will be the knee replacement model which I have, and in this is a demonstration model. And once the knee joint is arthritic, once the knee joint is not treatable with any other way, we will make a proper shape cut in this. This is the thigh bone, this is the leg bone. We will make a cut, and we will apply bone cement on this, and we will keep a femoral implant, something similar to this. And this is the thigh bone, and this is the leg bone, where we make a proper hole, and in this we place the component inside like this. And between these two things, as both these things are metals, they may be having some issues in erosion. We place a polyethylene, highly cross-linked polyethylene in between these two components, and now the patient will be able to walk on this. When he is walking, he will be walking on this. So the patient will not have pain, and the success rate will be around 96 to 9%, and complications will be around 1% or less than 1% in few centers. It varies from center to center. And knee replacement surgery is a successful surgery, and it has been a standardized procedure. Most dreaded in complication is infection, and that may happen at any point of time. It may be immediately after the surgery, or it may be few years after the surgery. And if at all there are any issues with component placement, whatever issues have arisen, we have to first diagnose them with CT scan or MRI or X-rays, and then we have to correct them accordingly. We can definitely go for knee replacement in both the knees in a single sitting, or if the patient is a bit compromised on his comorbidity side, we will take 1 day gap or 3 months gap for taking knee replacement, because according to studies, the amount of inflammatory mediators or complications are more. 2 knee replacement surgeries are done with 7 days or 10 days or 15 days gap. So either it is on the same sitting, or 1 day gap or 3 months gap. That is a standardized thing. And the life of a knee replacement, definitely there are patients who have got their knee replacement done 25 to 30 years ago, and still they are doing good in many centers. And it of course depends on patient bone quality, patient's quality of life, as well as the surgical technique and the implants. After surgery, knee replacement surgery, patient will be able to lead a completely normal life from 2 to 3 months, depending upon his aptitude and his muscle strength and his other comorbid conditions, and the way he has followed physiotherapy advice and in strengthening his muscles back. And usually it will be around 1.5 to 2 months he will be able to drive back, and he will be able to walk normally without any support. But for about 2 weeks, it is better that the patient walks with support. And usually what they say is the initial recovery phase for subvastus approach, where we don't cut the muscle, rather we retract the muscle to one side and do the surgery, is supposed to be, early results are supposed to be better compared to splitting the muscle and doing it. For knee replacement surgery, the patient has to get preoperative investigation, and in that we will assess his general condition, and as a part of that, his renal function, kidney function or liver function, and his hemoglobin level and diabetic status, everything will be assessed, hypertension, everything will be assessed, and based on that appropriate precautions will be taken. And in cases if diabetes is not under control, for example blood sugars are not under proper control, we wait until his blood sugars come under control, and then we will go for knee replacement, because knee replacement surgery is an elective surgery, it's not an emergency surgery. So we will wait to control other things, other health issues, health parameters to come to normal, and then we will go ahead with knee replacement surgery.